as my friend said that I am not going to thank the organizers for the topic, so Neeta is going to get the same comments again. But no, I must thank her because she made me read something new. I don't know how many of you are actually seeing sarcopenia or dealing with sarcopenia in clinical practice, but for me, I must admit it was something, to think about and read and learn, that is something which we must look for when we are practicing diabetes and obesity. So, thank you, Neeta, for the topic, and thank you, Sanjay. I don't have any disclosures for this. So, in this, presentation, what I plan to do is to touch upon the basic concept of sarcopenia and how do we go about diagnosing this. And management actually is very simple and very difficult, and you will know when I come to the management. So sarcopenia basically is derived from a Greek term which means poverty of flesh. Sarco is flesh, penia is poverty. Actually, the term now, some people say that it should be, renamed as myopenia because we talk of muscle mass. It was first described in 80s to describe age-related decline in lean body mass which affects mobility, nutrition status and independence. The definition since has evolved, and now the definition includes, muscle function, impairment of muscle function, and it is also now identified as an independent disease in the International Disease Codes with the ICD code of 10. Now, current definition says that sarcopenia should be defined as progressive and generalized skeletal muscle disorder that involves accelerated loss of muscle mass and function, both. It is not just the loss of muscle mass, and it is associated with increased adverse outcomes which include falls, functional decline, frailty and mortality, and usually has been described to define or label the age-related loss of muscle mass and function. Clinicians usually tend to associate sarcopenia with leanness, but it can be present in obesity also. And sarcopenic obesity is usually identified when both low muscle mass and increased obesity are present in individuals, and it can remain unnoticed because we are focusing on obesity or adiposity, and patient may have lean muscle mass, and when we are making them lose weight without advising them adequate exercise, this may be detrimental and cause damage. Now this slide shows how the muscle mass and function goes through the lifespan. If you see carefully, the first part, there is during youth or adolescent, there is sharp increase in the muscle mass and muscle function, which becomes kind of stabilized at peak around 20 to 30 years of age. And after 30 years, there is very gradual decline in muscle mass and function which happens through the life, and it gets accelerated after the age of 60 and rapidly declines after the age of 70 and 80. The function of muscle or muscle function or strength declines much faster or more as compared to the muscle mass. What are the pathophysiological factors which contribute to sarcopenia? There are a number of factors which have been thought to contribute. There is aging which disturbs skeletal muscle homeostasis. There is reduction in the size and number of myofibers, particularly type 2 fibers, which I'll show you in next slide. There is decreased muscle protein synthesis and increased muscle protein breakdown. There is blunted response to the anabolic stimuli, something labeled as anabolic resistance. Even if there is stimuli for protein synthesis, there is no protein synthesis happening. There is reduced contractile function of the muscle, increase in the adipose tissue deposition in between the muscles, reduced mitochondrial function and aerobic metabolism. There is deranged neurological signaling and control of muscle function. There are abnormalities in endocrine function, particularly the crosstalk between bone and muscle function. There is some evidence that there is age-related decline in production of a particular protein called apelin, which is an endogenous peptide produced by muscle contraction and is decreased marker of decreased muscle function. So this slide you will see as the muscle mass decreases, there is increase in the fat in the muscle, And this is the diagrammatic representation of how a normal muscle is in the young age and how you look at the muscle when it is sarcopenic. In sarcopenic muscle, there is more loss of type 2 fiber, which is the fast twitch fiber. So slow twitch fiber is the fiber which is involved in aerobic activity. It is more involved in the steady power and endurance, while the fast twitch fiber is the one which is involved in the repetitive or more vigorous exercise, and if it is not there, there is easy fatigability. So there are multiple factors which are contributing to development of sarcopenia. There are lifestyle factors, particularly decreased physical activity. There are multiple biological factors and psychosocial factors which may be involved, and they all affect not only the muscular system but also the neurological system and skeletal system. And in turn, they lead to discoordinated motor nerve function, decreased endurance, decreased muscle mass and coordination, and ultimately leading to frailty and sarcopenia. Now, diagnosis of sarcopenia requires a measurement of combination of muscle mass, muscle strength, and physical performance. It is not just loss of muscle mass which is important. And all definitions use at least two parameters, but there are different cutoffs and there is lack of standardization, so it is very difficult to apply these to clinical practice. Now, the latest one is the European Working Group on Sarcopenia for Older People 2, which has advised a stepwise approach to diagnosis, and it is as recent as 2018. So diagnosis starts with a measure of muscle strength, which is usually the grip strength test, which has well validated protocol and standardized cutoffs. If the grip strength is lower than the reference values for gender, then sarcopenia is to be suspected. And this shows that grip strength less than 27 kg for men and 16 kg for women, grip strength, if you are applying that pressure, if it is less than that, you can't do that, it is taken as abnormal. There are other parameters which can be included, which is gait speed of less than 0.8 meters per second, or timed up and go test which needs more than 20 seconds, or there is a appendicular skeletal muscle mass measured by DEXA. If it is less than 7 or 5.5, these are important parameters which can be included in diagnosis. So this is a stepwise approach suggested by the European Working Group, and first thing is the clinical suspicion. Elderly people, you should keep screening for presence of sarcopenia. If you are screening and you don't find any reason to suspect sarcopenia, they are in regular screening on a periodic basis. If you suspect there is sarcopenia, or if there is positive, SARC-F is a tool for measurement of for identifying sarcopenia, then you put them to the muscle grip test. If the muscle grip test is normal, then you have to look for other causes of why the muscle function is poor or mass is low. If the muscle grip strength is lower than the cutoffs, then possibility of sarcopenia is there. And once you feel there is a possibility of sarcopenia, then that is the point which should trigger all the evaluations for sarcopenia. It is not that you leave it there. And usually you have to go on with the muscle mass measurement using a DEXA. If the sarcopenia probability is low, then you can switch them to the regular screening. Now, second step is the measurement of muscle mass, and the most effective procedure is DEXA. There are several other techniques like bioelectrical impedance or CT scan, or even now the ultrasound has been suggested as a modality for measuring muscle mass, but we do not have any standardized cutoffs. BIA is a very good simple tool, can be used on bedside, but it has specific equations for different populations, and also according to the manufacturer, and there is lack of standardization. So again, it is not a very good technique, but it can be used for screening. Once measure the muscle mass using DEXA, and you feel that sarcopenia, if you are able to define sarcopenia there, then you have to do performance tests like time up and go test and gait speed. And if they are low, it is severe sarcopenia. If they are normal, you assess for the causes and start intervention accordingly. Typically, for muscle mass evaluation, we look at the appendicular lean mass, which I showed in the earlier table, and once sarcopenia is confirmed, you have to look for the underlying causes. There may be multiple factors which contribute to development of sarcopenia, like nutritional factors, low energy, low protein intake. There may be lack of activity, which is actually one of the major contributing factors, diseases of bone, joint, cardiovascular disorders, endocrine diseases, particularly androgen deprivation, neurological disorders. Cancers are commonly important cause of sarcopenia, and prolonged hospitalizations and drugs can also be involved. Treatment can be categorized as non-pharmacological and pharmacological, and we have recently published guideline, which is the International Clinical Practice Guidelines for Sarcopenia. It recommends that physical activity is the baseline or the mainstay of the treatment, is strongly recommended. In patients with sarcopenia, prescription of resistance-based training, which includes dumbbells or small weights or weight training machines, which may be advised to patients to improve lean muscle mass, muscle strength, and physical function. Protein supplementation is apology for the spelling errors, but protein supplementation is generally advised, though the evidence is not significant. So, increase in protein in diet or supplementation with protein supplements may be helpful, but it is to be combined with physical activity interventions. Pharmacotherapy, there is not sufficient evidence to use any drug for treatment of sarcopenia. Whether it is vitamin D or anabolic hormones, pharmacotherapy interventions as of now are not recommended as first-line drug. Now, interestingly, I came across this study published at ADA 2019. This is a DPP outcome study which looked at frailty in patients who were treated with lifestyle interventions or metformin or a placebo. And the idea of this study was to examine whether the odds of frailty differ in different DPP intervention arms. As we know, DPP, there were 3 treatment groups: intensive lifestyle intervention, metformin, and placebo, each arm involving almost 1,070 patients. And the DPP recruitment began in 1996. DPP results were out in 2001 with 3.2 years follow-up, and then the group was followed up for further 10 years. And these patients were screened for presence of frailty at 2,385 participants at 12 years post randomization, and another 2,200 odd patients were screened at 14 years. And they were looked for frailty based on standard criteria, which is Fried's criteria. 5 parameters: slow walking speed, weak grip strength, low physical activity, exhaustion, and unintentional weight loss. And based on the number of factors present, they were classified as frail, pre-frail, or non-frail. These baseline parameters of all the patients were very similar. Now, important thing is, if you look at this, there was no difference in placebo group and metformin group, but chances of having frailty were 37% lower in lifestyle intervention group. Again, reinforcing that lifestyle measures remain the mainstay for management of sarcopenia. So, the summary, again, lifestyle interventions were associated with 37% lower risk for sarcopenia. To sum up, sarcopenia is an important clinical condition and should be looked for, especially in elderly and with chronic illnesses. Diabetes and obesity can also be associated with sarcopenia. Regular and increased physical activity is associated with reduced risk of sarcopenia, and physical activity with resistant exercises is the first-line therapy for sarcopenia, may be supplemented with increased protein intake. Pharmacotherapy is not recommended. Thank you.